The future of healthcare may not be about making people travel further for care. It may be about bringing more of the care closer to them, not just through a video call, but through better diagnostics, smarter delivery models, and technology designed around access. Now, that sounds simple, but it's not, because changing healthcare takes more than a good idea. It takes persistence, leadership, capital, technical expertise, and a willingness to build when the market is not ready yet. Today, we are talking about what it takes to build that kind of vision. Let's start it up. Hello, and welcome to Stack and Startup, where we talk with founders, operators, creators, and business leaders about the reality of building something. Today, I'm joined by Charlie Nahabedian, CEO and founder of VK Digital Health. And normally I would just throw it to you at this point, but I want to read this portion because I think it's so important that you are a veteran entrepreneur with decades of experience across telecommunications, technology commercialization, and business leadership, and that you are focusing now on healthcare through a kind of like a telehealth, remote diagnostics, and integrated care delivery. And I find that incredibly impressive, and I am so thankful that you are here with me today. So, how are you doing?
I'm doing great, thanks. Um, it's exciting to share my perspectives with the audience. More importantly, what's driving me, what's driving the company, and why we think this is a worthwhile purpose when there are a lot of other competitive technologies in the market that we clearly don't think are doing the job.
Now, when you say competitive technologies, are you talking about like fitness trackers?
It could be fitness trackers, it could be plain telehealth,
Hmm.
where it's just an audio video call and they rely on the patient to understand what their symptoms are and their vital sign measurements are. It could be remote patient monitoring that may not be adequate. Um, and so, uh, especially uh, uh, when patients are discharged from a hospital, that's the most challenging case where they're put on a 30, 60, 90-day care program. And if they get readmitted related to the reason they were discharged, there's a huge penalty that that provider incurs by the insurance companies, especially Medicare. And so there's a financial incentive for them to find a better way. And they have tried various approaches. We think we have the best combination that's going to hit the market soon.
Excellent. So, and before we go on, because we talked about what the competition is, but we really haven't gotten an overview of like what you're doing and kind of who you are. So, um, short of going through the very extensive history, because looking at your LinkedIn, there is a lot to unpack there. If you can just tell us, about who you are and what you are trying to accomplish here.
Sure. Um, I started life off as a engineer with a bachelor's, master's in electrical engineering. I had 2 years of uh, service in the U.S. Army Signal Corps, where I did a lot of radio-based work. And then I started my commercial career at Bell Labs. And one of my first projects was managing the development and testing of the first cordless telephone. Now, you're too young to remember, but cordless phones came out commercially in 1982. Um, I was working with my team at Bell Labs in 1967 to 69 to test the latest ideas in cordless phones and gather the measurements needed to convince the FCC that they should make frequencies available for this service. And um, it was a cute, clever idea at the time. But what convinced me that there was a market for it was when I had two trial customers offer me something like $1,000 under the table if they could keep the trial units. One was a Mack truck salesman, and he actually sold a truck while he was out in the parking lot dealing with another customer, which he wouldn't have had that opportunity otherwise. The other one was a construction manager who had to come down from the scaffolding of a high rise if you wanted to make a phone call and coordinate supplies or manpower. He could do that right up in the tower where we had excellent reception. So I said, yes, convenience has a lot to do with what drives a market. And that was in the cordless, wireless space, as we call it today. Later in life, after that experience, putting coin phones on the high speed train in New York to Washington, after managing six groups designing the first microprocessor controlled all electronic business system, and uh, being the architect and program director for the touchscreen kiosks down at Epcot in Disney World for opening day. All those experiences taught me that it's not technology that's important, it's understanding the customer, understanding how they want to operate, and the importance of convenience and making it easy for them. And um, uh, later in life, when I took on a part time role as a favor to a friend, managing a senior living facility, um, I had the responsibility of getting seniors who do not drive to doctor's appointments, clinics appointments, or just walk in appointments because they were not feeling well or they needed to be checked out. And I literally had to go from one vehicle to two vehicles to serve that population. I had a manager who worked half time just to do that. And I said, this is nuts. There's got to be an easier way for seniors to get checked out, um, assuming they don't need to go to the ER. Um, and it was through discussions with an executive in a visiting nurse organization that I realized, yes, technology might be able to help here, and that is what spawned my group to steer away from international remittance, where we were applying technologies to solutions in healthcare.
And yeah, I mean, again, like I said, very, very long career. You talked about the cordless phones coming out in 1982. I'm personally very enamored with that particular year because I also came out in 1982. Uh, so I don't remember so you're right. I don't remember cordless phones really hitting the market as you said, but they were definitely big while I was growing up. We had some of the earlier models where I think they were sub 100 megahertz, and then they were 600 and 900. And I think the last one we had in our house was like a 1.2 gigahertz
Mhm.
phone,
Yep.
which my mom absolutely hated because she would try to take it from room to room. And of course, the higher you go up in the frequency, the less wall penetration you get.
Mm.
And especially since those were much lower powered units back in the day.
Yep.
And now we've got Wi-Fi in the 5 to 6 gigahertz range. We've got
Mhm.
cellular communications up there as well. One of the companies I worked for, we were testing the feasibility of 26 and 76 gigahertz range for telecommunications. Now, I don't know about you, but I don't really want cosmic rays in my pocket, which is kind of why it's in a bit of a holding pattern. But
Mm.
that is, like I said, it's absolutely amazing just how the technology has changed over the years.
Yeah, and there are a lot of as an engineer, there are a lot of technical considerations with respect to what frequency ranges you use, what power levels you use, what kind of antennas you use. Fortunately, I've had a little experience in all of those areas, um, but I didn't need as much of that, let's say, detail radio knowledge to figure out what is it we need to do in healthcare.
Right.
Uh, and that is clearly our focus today. And what we finally understood, well, we understood in the beginning, but we better understand it today, is the main problem for these seniors is convenient access. They don't like to travel. They don't like to go to the hospital unless it's really necessary. Um, and if they live in a place where it's a bother or a high cost to get to healthcare, they'll also put it off. So, and you can see that in the population health statistics. And, you know, there may have been a time where people said that was their choice. But we're now at the point of saying we can't have uh, as good a healthy population as we could have unless we do a better job of serving patients wherever they are. And is there a better way of doing it than has been done for the last 10 or 20 years? And the answer is yes. It is not um, uh, uh, a technology that I'm going to get a Nobel Prize for. I mean, I won't throw it away if they nominate me.
Yeah, I was gonna say.
But but the point is that almost all the technologies we're using already exist. Now, is there anything novel in what we're doing? Absolutely. Um, we have 4 patents issued, so there must have been some invention there someplace, and we put them together in a different way than most people think to solve not just one little problem, but a broad set of issues that, let's say, rural patients in particular face. And it gets back to understanding, you know, what the need is of the population you want to serve, and then saying, what's the best technologies to meet that? What is it that the medical side wants, and what are their requirements? Because that now becomes also critically important and relevant. Um, it was not much different than my project at Epcot. That project was originally a signed off deal between AT&T and Walt Disney World. Uh, Disney would design it, AT&T, the sponsor, would review it, Disney would implement it and operate it, and AT&T would pay their sponsorship fee. Pretty simple. Except 21 months before opening day of the park, Disney calls AT&T and T and says, "You know that little contract we have? It's a small contract compared to Spaceship Earth, which AT&T also sponsored. That little project, we don't know how to do it. We haven't got started yet. And opening day is fixed, October 22nd, 1982." And so I was sent down because of my development experience. And they said, "Charlie, figure out what to do and make it happen. And you've got the original budget to work with. And you've got the remaining time to get it done." And it was basically understanding what the needs were as Disney defined it and all they wanted that system to do, and then understanding the relevant technologies inside the Bell system, outside the Bell system, and build that architecture. Also understanding where the human resources were within the Bell system to get the job done and what Disney could do. And we put a multi company team together, allocated the money, did a little side agreement with Digital Equipment Corporation so Disney would get the AT&T discount with warranty transfer. Little novel negotiating there. And everything got done on time and within budget. But it takes someone that understands the needs, can build a plan, can make sure everyone stays coordinated on the timeline, meets the milestones, and gets the job done. And that's kind of the approach we're taking here in healthcare. All right. Understanding all the problems that are out in rural America. Initially, I've already got interest in Egypt and Africa, by the way. And how do we solve the healthcare needs in those rural communities? And
Yeah, there's definitely a lot of the underserved communities, both here and abroad. You mentioned the rural areas, and it doesn't sound like this is really as much of a technology problem as it's almost like it's a human problem. But is there any one particular technology within the past couple of years that you think made this more possible?
um, that's a good question. Initially, I would have said no. Um, we basically use technologies that existed. All the devices we use are FDA approved. Um, so we didn't need to create new devices that required their own FDA approval. Um, there are potential competitors out there that are doing scans and all sorts of um, new ideas with new technologies. Um, uh, they're not terribly successful, and they've got long approval timelines. Um, the all the technologies we're using already exist. They were putting them, as I said earlier, together in a new and different way. Yes, there's some trade secret in there, which allows us to perform with these multi technologies coming together. Um, but people have asked me, well, what about AI? Isn't that going to displace what you're doing? I said, I've been teaching entrepreneurship for 9 years in the graduate program in New Jersey before I moved to Maryland. And I had not the question on AI, it was on the latest technology while I was teaching. And there are companies that will be able to create a business just in that new technology and maybe apply it to a specific solution. But um, it doesn't replace the Amazons, it doesn't replace the Walmarts. There's still um, a need for products and services, but AI does sneak in there, just like all the other technologies,
Right.
to make it more cost effective, perhaps to make for more timely deliveries, um, and the like. And yes, we plan on incorporating AI in at least two or three areas in the total platform. And I only have two customers to worry about: the patient and the clinician. You could claim the medical provider that the clinician works for is a third, but I kind of lump the two of them together. So if I can satisfy each of them with lower cost, lower time, better access, better diagnostics, um, uh, then I will use AI where it makes sense.
Yeah, I actually recently sat down with somebody who is using AI in cancer research, which was an absolutely fascinating discussion. But that is a lot more focused and something that isn't necessarily going to reach the general public, other than the results of that research. And it sounds like your AI, it's going to be a mix of something that's going to be in house and also something that's going to be public facing. Is that fair to say?
Um, it'll affect the public facing.
Hmm.
It may not be obvious um, uh, that they're working with AI. And yeah, I think uh, there's a place there um, where AI is going to be very effective.
Just as long as it's not like going onto WebMD, typing in a simple symptom, and then all of a sudden it says you have cancer. Uh, if we can try to get away from that, that would be amazing.
The key thing with AI, at least as we understand it today and in the foreseeable future, is you don't want it to replace the clinician. All right. You want it to aid the clinician. You want it to aid the patient. And I gave you the rough parameters that we're working toward there. Um, AI to better detect cancer is really a process that someone used had maybe manually done in the past, or maybe with some technology to aid in that manual process. But AI is going to take it to the next level and do all that computation quicker and faster. That's redundant, but and maybe better. Okay, and is that a separate business? It could be if they're the only company doing it. But if there's another company that's in the business of uh, diagnosing whether that's cancer cells or not, they may just buy that little company that had the new technology, and it's basically a company with a broader technology base to do the job better and quicker.
And don't worry about being redundant. As a former engineer myself, I have a tendency to be repeatedly redundant myself.
What?
uh,
And if you're a good engineer, you have some redundancy built into your system,
Absolutely,
so
absolutely.
there's
I
no
think that
single point of failure.
Yeah, I think that's where that kinda comes from is, like, we're used to building that into our systems, and that's where engineers can, not always, become good business people because they understand that there's needs to be redundancies built in. So where do you think that traditional care models create the most amount of friction for patients? And I mean, one thing that you brought up is distance,
Mhm.
because, like you said, in rural areas, your nearest hospital, your nearest clinic, your nearest urgent care could be 45 minutes, an hour, 3 hours away.
Mm.
Beyond that, what can cause the most amount of friction?
Uh, the There was a Harris poll that confirmed cost and time, distance implied is indeed an impediment for rural patients to seek health care. But there are others. Um, because I tested a remote patient monitoring system. It was a bother, to use kind words, to daily uh, take a reading and then figure out how to upload it to the cloud because it wasn't as convenient as they claimed. And but generally, it was only 3 to 4 vital signs. And what I realized, just that's an inadequacy if someone's not feeling well. Um, that 3 or 4 or 5 measurements tells the remote clinician, yeah, something's not right. You need to come into the office. Well, then you hit the other impediments of time and distance and cost. So I said, no, that's not adequate for me. I want a solution where we take all the measurements that are important as if they're in the clinic already and it meets the requirements of the clinician that they're reading the results directly. There's no interpretation or misinterpretation by the patient, and it's easy for the patients to use. So there's no use restriction. And when you do that, the clinician can prescribe any medicine they would if that patient were in the clinic. And that saves them a trip. And so now adoption will be quicker and better. So now it's a matter of how often do you have to make the visit to that patient? Well, that depends on their care plan. Are they discharged because, they just had surgery and they need a daily visit? Or is it they have a chronic condition and they need to be checked maybe only twice a week or once a week? So that care plan is being prescribed by the clinician at the medical provider. And we just need to be sure that the solution is lowest cost capital cost, all right, and lowest cost operating costs because the you can look at telehealth. It's low cost in both of those, but it's inadequate. You can look at remote patient monitoring. It's low cost in both, but inadequate. You can look at visiting nurses and you can get all the measurements with a visiting nurse, but that's more costly. There are mobile clinics the size of a mobile home that have a doctor and nurse in it. And those are costly capital cost wise. and they're costly operating cost wise. And the third reason that's not a great solution is that with a shortage of doctors, some medical providers are having trouble getting doctors to even drive those big mobile clinics. So there's got to be a solution that doesn't have all those disadvantages. And that's what we're trying to create.
Yeah, we've definitely seen a massive shift away from the medical profession for a number of different reasons. The pandemic being a biggest cause of that. I personally knew this one nurse who she was an amazing person, but got burned out so hard,
Mhm,
and even with all of her training and all the money that she spent to become a registered nurse, I don't think she's ever going to go back to it again, and that is just absolutely devastating. Not just, and it's not that she didn't care.
mhm.
It's not that she didn't care because she still does care. Um, it just it's one of those things that just burned her out. Now, and when we talk about telehealth and how it's inadequate, um, and diagnostics, like I'm close enough to I use VA, being a veteran myself, and it's a little inconvenient, but not terribly inconvenient where I'm from to go into the clinic. I've had a couple of medical devices that would then phone back home to them through my cell phone, whatever.
Mm.
But I've never really used telehealth in general. How is that inadequate, and how does your system attempt to change all that?
Well, in some of those telehealth applications, um, it is it's possible that there's only one or two or three vital signs that are important to be monitored, and uh, and if that's adequate, and those uh, the medical provider knows you, you're not a stranger to them, and they trust that you're going to provide those readings reliably, then it may be adequate. I'm not saying that I'd throw out the whole telehealth industry. There are situations where telehealth will make sense. There are situations where remote patient monitoring will make sense. The point I'm making is if you look at rural America, telehealth and remote patient monitoring have been around for at least a decade, and they still have bad chronic disease statistics. They still have high readmission rates. So they're not adequate solutions by themselves. So that's what we're trying to solve.
Okay. And how do the remote diagnostics change the value uh, on a virtual visit?
Okay. Probably have to dig slightly a little deeper. Um, in our, we've got several solutions on the board. We've got one go to market solution. That go to market solution is using a smart clinic chair in a sprinter like van or small truck with one or two chairs in it. Um, and so that chair uh, looks a little bit like the chairs you see in a drugstore where you take your blood pressure.
Yep, the little cuff thing. Gotcha.
Yeah. But instead of one or two or three readings, we're taking almost a dozen.
Okay.
Yes, the patient applies the devices and we make it easy for them to use. And they do that as part of an interaction with a clinician. So those results are being read directly. Uh, Now, if it's in a uh, let's say, an assisted living facility, it's stationary, and there'll be an aide to help some of those seniors that need it, that if they're not ambulatory. Um, and that'll be a huge benefit to those seniors that don't have a doctor in their facility. All right, because seniors do have chronic conditions, um, and they generally have more than one, and they do have symptoms that act up, and they don't know whether to dismiss it as old age or a uh, a reaction to one of their chronic illnesses, and their choice in some facilities is to call 911 or pay for a doctor's visit at $120 or more. And those seniors generally can't afford that. And they
See,
don't want to go to the ER, so they postpone that. So their health gets worse rather than better. Uh, the go-to-market unit would be with the van or small vehicle. That vehicle could be an autonomous vehicle, or it could be driven by an Uber driver because they don't have to be medically trained. The exception is if the medical provider expects they're going to have to do blood draws or other body samples, they could designate the driver to be a trained phlebotomist. But still, that is a relatively low labor rate compared to a nurse, compared to a doctor. So we're basically sending that vehicle out with a minimum capital expense and a minimum labor expense. Um, and that can be scheduled, it could be on call. There are software programs to deal with it. Basically, what's built in to our software platform will be something like an Uber app. All right. So they could be called, they could be scheduled, the patient can be alerted when to expect the clinic in the front door. And there are variations on that solution if they're not ambulatory. Um, so it's a ideal solution. Now, one of the problems, I didn't want to get too technical, but one of the problems with telehealth and remote patient monitoring is also connectivity. Well, people say, well, they just dial it up on the internet. Well, in rural areas, there may not be any internet. Uncle Sam's
right.
been subsidizing fiber to rural areas for at least a dozen years, and we still have places where there's no internet. So,
Maryland's actually a really great example of that, because when I first got here, I'm a transplant to Maryland myself. When I first got here, Verizon was starting to spread out through government subsidies. The problem is that as soon as those subsidies stopped,
mhm,
Verizon stopped expanding.
mhm,
Like, they could have taken all the money that they were getting in month after month. I know I've been with them for over 15 years and
mhm,
continue to expand, but they chose their bottom line, which they're right to do,
mhm,
to not do that.
mhm.
And you're right. If the subsidies aren't there to serve those rural areas, then, you know, I mean, there are cell towers all over the place, but
Mhm.
unless you're like right next to a highway, you still may be underserved.
I am next to a highway where I live, and I happen to have Verizon wireless service. And I will tell you that the coverage in my condo is 1 bar or less. Okay. And finally, I complained to Verizon, and I have a microcell. right in my condo. It's technically 4 feet away. And I got 4 bars now throughout the whole condo. um, the, and if and I'm in a suburban area outside of DC. I'm not out in the farm country.
Right.
Okay. Um,
Although for Maryland, that could also still be a half mile, but that's just because Maryland is like America condensed.
right, right. So the the clinics that we roll out will have radio connectivity of different kinds, and we'll have the intelligence to determine which radio system we use: satellite, cellular, or could even be Wi-Fi if we're in a semi-public area and there's Wi-Fi available. So it has to have that flexibility, okay, so that you have connectivity when and where you want it. And the software will basically be um, a node, basically a node off the hospital or medical provider system. So everything that that clinic does is going to be registered, copied, inserted into the medical provider system. Well, I should say systems plural.
Right.
Okay.
Well, I mean, even if you have multiple systems, it can still function as like that one main system in of itself. So I think the word choice is still good
Mhm.
there. I want to take a little bit of a tiptoe through trust because if anything, that 2020 up to when things started opening up again has taught us is the importance of privacy in the medical field, and I think that does go a little bit beyond just HIPAA compliance. A lot of people were concerned about that, obviously, and I think that is still 100% valid. But how do you? Because you said these vans could be driven by anybody, and I'm going to assume for the moment that you are going to vet people a little bit better than your typical Uber app. Uh,
Mhm.
uh, but how do you make sure you gain that trust, especially for seniors who may, because of diminished capacity, because of just how much they're targeted by scams these days? How do you gain that trust uh, with these platforms?
Uh, One of the ways is with trials and pilots, and um, and also validation studies. So we have one medical provider who's most interested in doing a validation study with a dozen or more doctors, a dozen or more patients, and gathering the and performance statistics to claim that indeed the platform does what we advertise it can do. Um, but that's just one piece of it. A broader piece is partnering with a medical provider to serve a geographic area and some population with known demographics, and uh, customizing the workflow necessary to make it efficient for the deployment of the mobile clinic, but also make it efficient for the clinician um, who's doing the examination with respect to their workflows, and gathering the performance data that's relevant to that operation. Okay. So that's another layer on top of an in house doctor patient validation study. Um, uh, but we believe that we can, because we're using existing FDA approved devices and all we're doing, I'm oversimplifying it, all we're doing is moving digital signals from one place to another, much like AT&T or Verizon does over their telecom networks or internet networks. Um, the only other thing to do is to ensure that everything is number one, HIPAA compliant, as you mentioned, but also meets the high trust requirements. And that basically says that the interfaces and the telecommunication links and all of the remote access that we need to support the platforms uh, have the appropriate encryption and other password like devices or techniques in there that they can't be easily hacked.
Yeah, absolutely. Because not only am I deep into IT for a number of years, I'm also very serious about security. I personally I use tokens as my security platform, MFA obviously, and so yeah, that security aspect is important to me, and that's just transferring scripts or
Mhm,
video.
mhm,
This is nothing compared to, like, personally identified information, and I know that you know this, and it does sound like, you're gonna be utilizing the technologies in a responsible way because we have seen, how many times in the news have we seen a retail store, "Oh, there's a breach of, you know, 10,000, customer information," and it may just be names,
mhm, mhm.
but it
Yeah,
also could be finances,
mhm.
credit card information, and that could be absolutely devastating. So yeah, making it harder. Unfortunately, can't make it impossible to hack. um, I'm sure if anybody was persistent enough, they could like take that Spur van and just like, hey, eh, especially like in high crime areas. Because you're probably still gonna have to serve those as well, right?
Yes. Now there are ways of serving, um, let's say, urban blight areas, um, urban deserts, um, and and in some cases a stationary unit, like I mentioned. In other cases, it's a mobile unit. But we also believe that the architecture and the business model lends itself to franchising these clinics after a few years when we have the financial data to meet franchise requirements. Yeah, and then franchising will not only help provide solutions in those voided areas today, but will also provide a bit of economic development in those areas. And there are ways of doing that. So, yeah, I think there are some great possibilities with what we're doing. Uh, we've touched on, um, uh, the convenience aspect for the patient and access. Um, and we've touched on economics with respect to capital cost and operating cost. But from the medical provider's perspective, I've only touched on that lightly. Um, they there is a greater emphasis by the federal government for medical providers to be totally responsible for the population of the patients outside the brick and mortar. And they have to define their geographic areas that they're responsible for. And so that question of readmissions becomes important because the penalties for readmissions can be anywhere from $2,000 to $20,000 per patient per incident. So these medical providers are at great risk if patients get readmitted through some complication from the reason they were discharged. Um, but there's another financial aspect, and that is there's a market out there in those rural areas that they have not capitalized on in the past. And with a mobile unit, they can do more than just recently discharged patients. They can do, as I mentioned in passing, patients out there with chronic illnesses, diabetes, heart issues, pulmonary issues. But there are also people out there that haven't seen a dentist, haven't had their hearing tested, haven't had their eyes tested, um, would have to travel at least a few hours to get the prescription that they were just given. So we're talking about putting a lot of that capability into these mobile clinics. So um, you have the as much convenience as you can provide that rural patient to get them as healthy as possible. And I don't know what your personal history was before the iPhone came out, but most of the technologies in the iPhone already existed between what they call personal digital assistants and cell phones. All right. Apple, and I'm oversimplifying it, uh, basically combined all of those, add one or two features, and all of a sudden you had humongous capability in this iPhone. And that convenience is what got it so popular so quickly. And what we want to do is make healthcare access infinitely convenient. And now you've got motivation for people to use it and for people to get healthy because in the process, they will become educated, they'll change their attitudes and start being more concerned about their personal habits because now you're giving them feedback that you know your blood pressure was a little high, but you can bring that back in shape if you change this behavior. We'll be back next month and make sure, or next week, and be sure there's positive change. So uh, we can do a lot by giving people convenient healthcare access.
I definitely agree, and I remember the days before iPhones, smartphones, what have you, and I was a cargo pants guy. And I was a cargo pants guy because I would have a cell phone on me. I would have a portable CD player. I would have my HP iPack digital personal assistant, which I absolutely love and hope to never see again. Uh, I don't need to go back to some of those things. I actually do like having all that in one pocket. Now, I kind of want to talk about some of the ambition that goes behind this idea because so this company, VK Digital Health, it's essentially a startup, right?
Correct. It's a 10-year-old startup. Uh,
Okay.
well, technically, you could say it's only 6 years old, but we started earlier under a different mission, a different name, and in 1920 we reincorporated and we renamed the company with a clear mission like we have today.
Okay. So I mean, but even still, 6 years ago, starting it, and I'm gonna put not too fine a point on it, but at your age, a lot of people wouldn't be doing that. A lot of
Mhm.
people would, say, "Hey, okay, I kind of have this idea. Maybe I'll jot it down for a future generation, but you are actually doing it. You're trying to drive this technology forward. And where does that ambition come from when you potentially don't even need to do it?
Uh, you're correct. I don't need to be doing this. I could be living a lot easier life if I wasn't pumping some of my funds into this company. Um, but it was like any of the other technologies um, uh, that I've worked on. You see the benefit, and you see that the world isn't going to get there quickly unless you make the difference because you have the vision, or in this case, I have the vision, um, and my team members have the vision. They've stuck with me since the beginning, and we've bootstrapped it for all this time, which means we've had other incomes. Yes, um, we've had tight times, all of us, but we see that nobody else is really tackling the problem well. And we see where we have a solution that will. Um, and that drives us. Um, I like to tell people that it also gives me purpose. All right. Um, yeah, my purpose is not, reshuffling books on the library shelves as a volunteer.
Right.
That doesn't excite me. But what does excite me is finding and trying to deliver solutions that I think will move the world to a better place sooner. And and have I been advised, give it up? I can say various members of my family have questioned my commitment,
Right.
uh, and I said, I think I'm doing this smartly. I've got committed team members. They believe in what we're doing, and it's like being on the soccer field today. No one player wants to be responsible for the failure of the team um, when you have a good goal to go after. And our goal is winning this healthcare access um, challenge.
I think that's an absolutely amazing story. For me personally, I was I've been a worker for most of my career, and in a couple years ago, I was doged out of my position, and the market was flooded with a lot of people like me, a lot of IT technicians, brilliant people. And so trying to find a job was next to impossible. And I thought, am I? And you're probably going to laugh at this, and I'm welcome you to laugh at this. But am I at 43 years old going to start over and build a business? Is that purely insanity there? And I would see some other older founders. One of the things I watched before starting up this SD Tech franchise was the founder, the story of Ray Kroc, and how he started at 52 years old, and it got me thinking. Okay, the dude became a multi-billionaire after his 50s while selling milkshake, actually just doing odd jobs throughout his career.
Mhm,
Maybe I can quit whining about being 43.
mhm. Well, a couple of little points about me. Along the way, I picked up my MBA in finance and marketing, um, and um, I later taught entrepreneurship in the MBA program for 9 years as an adjunct professor. So I understand. not just the technology aspects, but all of the marketing and finance aspects of building a business. And I left the Bell system after 20 years at the age of 47, which is why I'm not laughing, because that's when I did my first startup. And I had an opportunity to start the company with a $1 million contract, and that was too good to pass up. And I recruited in 10 months about a dozen employees with all the right experience to design from scratch a portable handheld cellular telephone. And what normally in those days took 2 to 4 years to design and build, we had a pre production model built and working in 10 months. And I was on my way to becoming a multimillionaire. Um, Except we had a little thing called a stock market crash of 87, one of those exogenous factors that you don't predict.
Right.
And it did, unfortunately, alter the outcome. But the point is, I had something to sell and I sold it, not for the money that I was hoping for originally, but it got a little company called LG started in the cell phone business, and they had a pretty good run for a good 30 years,
I did, yeah.
starting my team and my original design, which was their first production unit. Okay, um, so yes, uh, and then I did have to contemplate my navel, so they say, and say, what am I going to do when I grow up? Because at that point, I was about age 50.
Right.
Um, and I thought I had at least a couple more years to go before I retired. So, um, yeah, it is. I think the good thing I can say about you and me and others like us is we take an honest assessment of what the new conditions are and where the new opportunities might be. And we're willing to try. Um, did I jump from that venture into this one? Oh no. I had many other,
Your LinkedIn proves that.
yeah, I had many other career assignments. There's a lot not on LinkedIn of all the ventures that I helped get started or almost started or started and withdrew from. Um, you get to learn uh, where you want to dip your toes into and make sure you don't get burned too badly along the way. This one uh, was too good to pass up. There's a huge, huge benefit, um, and um, we we believe that we had a very tight core team with the expertise to pull it together, and we've got partners that we think will help us bring it to market. Our big challenge is I didn't realize um, that in the healthcare field, so many people came from Missouri. Uh, if you recall, Missouri is a show me state.
Right.
And so they want me to show them before I get their investment or commitment. That's changing a little bit, but financially, it's still pretty tight out there. But we believe we're going to get to certain milestones that will convince um, certain investors to commit and certain providers to commit. And that'll be enough to get started, hopefully within the next 6 to 12 months.
That is absolutely amazing. I've also been asked, even at my uh, younger age, how it is I can keep up with the technology because as you know and seen and experienced and drove, the
Mhm,
technology changes so rapidly.
mhm,
And one of the things that I say is that, I love the technology so much, but I do feel like I'm going to school every day,
mhm,
trying to keep up with the technology. And I do it because I love it. Like I said, I do it
mhm,
because I love it,
mhm.
but it is something that I do have to put a lot of energy into. Is that something that you find is similar?
Yes, I do have the benefit of team members who have complementary experience and knowledge, and I learn from them. I'm not afraid to question them, challenge them, and adopt what makes sense that they recommend. And that's a good way of keeping up with it. But people say, "Oh, this artificial intelligence is all new." Well, is it?
Not
Uh,
really. W-
I
w-
can tell you that in 1990, roughly 1990, I can't peg it exactly. It's not on my LinkedIn. I was a I was a market rep for 6 to 9 months for a company out of Massachusetts that was using artificial intelligence. Now, they called it artificial intelligence, and it was basically software that did some very fast mathematical calculations on visual items, visual images. And I actually got them into um, several potential contract areas and then decided to move on. Um, but like any technology, it evolves, it gets better, generally speaking. And my only challenge was to understand the current version of AI and how is it different from the last version of AI. And once I understood the basic difference and how that translates into different kinds of capabilities in different AI models, all of a sudden I'm almost an expert on AI. I say almost. At one point in my career at AT&T, I was director of regulatory affairs for all of the customer equipment that AT&T had in customer facilities around the country. And my organization determined what the rates and tariffs would be. And this was before deregulation.
yeah,
And it was a brand new organization. Um, and I'll skip all the whys and wherefores.
and all the
But
baby
in any,
bells and all
yeah,
that. Yeah.
but AT&T had in their headquarters a regulatory organization, and they said, "Oh, this new division has a regulatory director. We'd like to know what he's going to do." So they invited me to present something about my organization. So I went to one of my regulatory experts and I said, "I got to put this talk together. And here's what I think I'm going to cover. Um, but I need to anticipate what questions they might ask." And um, and the regulatory person said, "Doesn't matter what the question is. The answer is it varies by jurisdiction." And then you can expand on that if you want, but you don't have to go very far.
Right.
Um, and when people ask me, how am I going to deal with all these different medical providers? I say, it varies by provider. All right. I need to understand who they are, what services they provide, what geography do they cover, what demographics are in within that geography, what level of services do they want to provide, and then I can adjust the capabilities in my clinic and my platforms that connect the clinics to basically make them an extension of what they have and do it better. And I've got the financial wherewithal to do macroeconomic studies, microeconomic studies, cost benefit analyses, because all of those are relevant in understanding how to put all these little pieces together and make it work right.
Yeah. Like I said, a lot of this is just kind of like blowing my mind as to where we're going at, and just like I said, the ambition that you have, and gives me a little bit of a boost, saying, it's like, okay, you know, I'm not too old, because I don't know how my own future with this company or with future companies are going to be.
Mhm.
Because like I could potentially do this for 10 years, sell out, and go live off grid or something, and be happy. But I do think that I might be closer to where you're going, and like if I stay there for more than 6 months, I'll just be like, I got to do something. um Charlie, this has been an absolutely uh amazing conversation, and like the biggest takeaway from what you're doing now, it's more than just putting a doctor on a screen or putting a doctor on a set of wheels. It does sound like it's bringing the right care closer to where it needs to be, and I think that in of itself is just absolutely amazing. And before we do sign off, I'd like to give my guests, a couple of questions, to finish up the episode. And the first one is, where can people find you?
Ah, I reside in Maryland, um, and
We don't need to give your address, but like your
no, 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 I understand. But you can go to the website, um, vkdigitalhealth.com, and you can certainly put in a request to talk to me, and that's a good start. The other one is LinkedIn. Um, I do a lot of my connections and initial communications contact through LinkedIn. And if people have a legitimate request, I generally honor it. I've had college students reach out to me, and I take the time for them because they're our future generation. But and I certainly will respond to leaders from companies that are most relevant to our needs.
excellent. And the last thing is for the founder, the healthcare leader, the technologist, or business owner who is listening to this, viewing this video, and who has a big vision, but is realizing that the road may be a little bit longer and harder than they expected. What words would you leave with them?
Well, first thing I'd like to say is um, we're a small team, and we're not going to conquer the world by ourselves, and neither will any other small team. You need partners, you need good partners. And so, if any of what I'm covering sounds relevant, I'm always happy to explore synergies. For other companies that are in spaces that don't touch on what I'm doing, uh, I'd say, be sure to understand um, what the benefit is to whom, and make sure it's a large enough benefit to warrant the effort uh, and the expense of your solution, and then seek partners that can help move you along a little bit quicker. I am a firm believer in networking. It's good for looking for a job. It's good for looking for a partner in life, personally, but it's also good for making sure your company is successful. And so I would say network and know how to filter those contacts that are most mutually beneficial and try to cultivate those.
Good words. Good words. I do want to thank you so much for joining me, and for everyone who is watching or listening. If this conversation has made you think differently uh, about healthcare access or technology, particularly persistence, or what it means to keep building a vision over time, that has been the point. I since we had that first pre-podcast talk, I've been really excited about this particular conversation because it does show that, again, to me, that persistence can pay off to build something that you want to build,
Mhm,
and that the future doesn't just become real
mhm,
because someone predicts it. You have to actually build it.
mhm, mhm.
So, thank you everybody for tuning in to Stack and Startup. If you've enjoyed this episode, make sure to like and subscribe so you do not miss future conversations around business, technology, and growth. You can also find us anywhere you get your podcasts. And if you want to directly support the show, you can become a patron at patreon.com/stack and startup. Until next time, I want to leave you with a couple of names. Ray Kroc, who I mentioned earlier, 52 when he started the franchise to McDonald's. Bernie Marcus, 50 years old when he co founded Home Depot. Colonel Harlan Sanders, 65 when he started Kentucky Fried Chicken. Don't let your age tell you when you can start, and we'll see you next time.
Thank you.